patient? Think logically.
Yes. Yes. There's no history of chronic cough. There's no history of lower urinary tract symptoms. There's no history of evening rise of temperature, or there's no history of swelling in the legs. There's no history of burning micturition or any periurethral discharge, and there's no history of prior instrumentation. Sir. Personal history: the patient has no comorbidities and he has no addictions. The fluid intake is 1.5 to 2 liters per day. The urinary frequency is 7 to 10 in the daytime and 0 to 1 times in the night. Bowels: he passes stools daily, soft stools with no straining. Diet is predominantly vegetarian diet. Treatment history: there are no prior hospital admissions and patient is not on any regular medications. The clinical examination: the BMI is...
Hello. Hello. Am I audible? From CECT, I'm Dr. Lalit. I'm discussing today.
Yes, you're audible, sir.
Is there any history of undescended testes in the childhood?
No, sir.
Is there any family history of testicular swelling or testicular tumor in the family?
No, sir. There's no such history.
Any prior history of testicular swelling in this patient?
No, sir.
So, sir, any history of inguinal swelling?
No, sir.
Hello.
There's no history of any inguinal swelling, sir.
Okay. Sir, based on the history, my differential diagnosis would be hydrocele and testicular tumors. Yes, sir. Only these two would be my DDs.
So when we look at scrotal swelling, he's 70 years old.
Yes, sir.
So this would not be your usual testicular tumor. Do you think only of scrotal swelling, or do you think of inguinoscrotal swellings when a patient comes like? What would be commonest in a 70-year-old based only on the
inguinoscrotal swelling would be commonest, but as the swelling is based on history, it look like only scrotal swelling. So that's why. But of course, on an examination, I will examine for hernia also.
Okay. So the idea is at this stage you have to keep all your options open, and rather than just saying hydrocele and testicular tumor, I would say inguinoscrotal swellings, possibilities, and scrotal swellings. In the scrotal swelling, in the scrotum, in the testes.
Yes, sir.
Okay?
Yes, sir. Next slide, please. Examine.
Any other history that you would like to complete here? Can we go back to the previous slide?
Yeah.
If you're thinking of a tumor,
Yes, sir.
have you ruled out, based on the symptoms, that it could be a metastatic disease?
Yes, sir. I would. This cough, they have already experienced no history of cough, so and no history of pain in abdomen. I would ask, sir.
Yeah, as a general rule, cough hemoptysis, weight loss. Okay, we'll go ahead, sir.
Yeah, sure, Manish. Your case. Go on.
Clinical examination. The patient's BMI is 17.3 kg per meter square.
And next, please.
Before you say next, maybe at the end of the slide, you can say if something is abnormal, what's abnormal. If something is normal, you can say nothing here.
Okay. BMI is lower side, sir. Rest everything is normal, sir.
What is the WHO reference range for blood pressure?
Sir, first systolic 120 to 139 and diastolic, sir, 80 to 89. It's up to this, it's a normal, sir, upper limits.
What is the American cardiology reference range?
Yes, sir. Sorry, sir.
HCI keeps changing its goalposts frequently. The Joint Commission effect.
Every specialty has its own range now. Yeah, just keep a watch on the diastolic pressure. You can go ahead.
It's it's all right. Next, please.
You comment on the swelling and then you
Hello.
anything
Have they told
abnormal in
you
this?
on clinical examination, can you make out the organ of origin, or is it left out as of now? Would you like to know?
Sir, these are only inspection findings, sir. On inspection, it look like scrotal swelling. And scrotal skin over the swelling appears normal and it doesn't reduce when lying down. No cough impulses, sir.
Okay.
Look like
Not
scrotal
only
only,
just
sir.
inspection findings, but what all can you make out? That's what Prabhu wants to know.
This is not very difficult to answer.
It's spherical, sir. So
If it was a spherical swelling, would it be a 6 into 6 centimeter? If it was a hydrocele, would it be 6 into 6 centimeter spherical?
it won't be spherical, sir. It would be globular if it's hydrocele.
What's the difference between spherical and
No,
globular?
sir. When the length will be more and the width will be less, sir. Oval shape. You can say, sir.
Okay, so a hydrocele would probably take the shape of the scrotum itself, and it would not
Yes,
be
sir.
an isolated spherical swelling.
Yes, sir.
The skin not being involved, what does that tell you? The skin being normal.
It means whatever the swelling, it is not adherent to the skin, sir. It has not involved the skin and extra testicular tissues, sir.
Could the skin have been red and inflamed and
Yes,
edematous?
sir. Epidermolysis, we could have been suspected it, or any abscess if the skin is red or.
Could the skin have been shiny?
Yes, sir. In abscess, it can be shiny also.
Any other condition where the skin might not be red It might be shiny.
In hydrocele also, there sometimes.
Yeah, in a hydrocele also, depending on the size and location, skin might be stretched and shiny. Okay.
Yes.
You have to tell them to proceed.
Okay. On palpation, no local rise of temperature or tenderness. Left side testis is normal in shape and size. Right single testicular swelling of size 6 by 5 centimeter, spherical, hard in consistency. Right testis not separately palpable, non-reducible. Getting above the swelling is possible. Cup impulse absent. Translucency test is negative. Fluctuation test negative. No inguinal lymph nodes palpable. Bilateral spermatic cord examination is normal. Please next slide.
Please tell us what you think with these findings, and then we'll move to the next stage.
Sir, it look like testicular swelling only, sir, and it is hard in consistency. So,
See, once you have palpated, it is no more just a swelling, isn't it?
yes, sir.
What you want to say is that it is a
Testicular-
testicular mass
Testicular, yes,
or a
sir.
testicular tumor, depending on
Yes,
which way you want the discussion to go.
yes, it's a testicular mass, sir.
Testicular mass, no extension along the cord, nothing present in the inguinal region, no lymphadenopathy.
Yes.
Anything else which is missing here, which you generally look for?
Any abdominal mass, sir?
No, local examination.
Okay.
Testicular sensation?
Yes, sir. Yes, sir. Testicular sensation is missing, sir.
It has not been mentioned. People generally expect you to mention that.
Yes, sir.
Why are they saying no, and the no is in big bold letters? No inguinal lymph node palpable.
Typo errors, that's all.
Sorry?
I think typing errors.
Typing, no, why no? Whether it's typing or not, obviously, the rest of it was all right. Somebody wanted to emphasize the no, I think. Make it loud.
Are you surprised that in testicular tumor there are no inguinal lymph nodes? Are you specifically looking for it?
No, sir. Normally, inguinal lymph nodes are not involved in testicular tumors.
How can they be involved?
Sir, if there any prior history of total surgery or inguinal hernia surgery or any
So,
biopsy,
without surgery, can't they be involved?
yes, sir. Without
Question
surgery,
is,
they can
if
be
you
involved.
find a couple of inguinal lymph nodes enlarged and a testicular tumor, is there some mechanism by which the inguinal node enlargement is due to
Yes,
the testicular tumors?
Sir, they can enlarge from this retroperitoneal lymph node from back direction. Also, they can enlarge. Sir.
What other routes?
I don't know, sir. Whether it's-
Do any of the coverings of the testis drain into the inguinal nodes?
Yes, sir. This this visceral mesothelial layer, sir. Over
Sorry?
the testis. Over the tunica vaginalis, if involvement of tunica vaginalis or spermatic cord is involved, then inguinal lymph nodes can be enlarged.
Yeah, therefore, if there are no inguinal lymph nodes specifically mentioned, you can rule this out. If there are inguinal lymph nodes enlarged, then you think of whether it's spread somewhere else, whether it involves something else, or whether it's a primary arising in one of the structures involving the testis. More importantly, do you find inguinal lymph nodes palpable in a normal individual? A routine clinical examination.
Sometimes you can get retrograde spread once the nodes on the top end are blocked up, or somebody has had some surgery in the abdomen, and where those nodes are gone, or that pathway has been occluded for some reason, then there's always a retrograde backflow into the inguinal node. So you don't know what this stuff is happening here, but these are the mechanisms by which inguinal nodes can be palpable in testicular tumors. Right.
Shall we move?
Please.
Yes. Sir, abdominal and abdominal examination is normal, sir, and digital rectal findings are also normal. Grade 1 prostate is there. Please, next slide. Please proceed.
So your differentials have any changed, or it's obvious now?
Yes, sir. My differentials is testicular mass only, sir, now.
Always specify right side, left side, localized.
Right localized testicular tumor, sir.
Okay, how will you like to proceed?
Sir, I would like to proceed with routine blood investigations and USG scrotum with tumor markers, sir.
Before you proceed, can I ask you one question?
Yes, sir.
Prima facie, looking at this patient and examining him, do you think there's any adverse factor here, considering a diagnosis of testicular cancer, just on clinical grounds? Just on clinical grounds, is there an adverse factor here?
Which is against our diagnosis, testicular tumor.
No, it's not against your diagnosis. The diagnosis
Sorry,
is...
sir, what, sir?
But is there any adverse factor here on clinical grounds?
In favor of our diagnosis, sir, or against our diagnosis?
No, it's not against your diagnosis. The diagnosis is testicular cancer. We are not refuting that. But I just want to know, on clinical grounds, are there any adverse factors here on clinical examination?
See, when we say adverse factors, we mean in terms of prognosis and treatment and so on, not necessarily for or against your diagnosis.
Sir, BMI is 17, sir, so.
No. But
The
that
build is.
doesn't matter. Let's proceed. We'll come to that answer later on. How do you find it? Proceed.
So
Sir, tumor markers are normal in weight, sir. USG scrotum.
Is it good or bad? Tumor markers normal for the patient. This is related to the question Dr. Ganesh asked you. On the whole, is there anything adverse about this patient's profile? Now we have the tumor markers also. Combining everything, does this look good? Does this look not so good? Or does this look very bad?
Sir, it looks good, sir.
I think you didn't get the import of Dr. Ganesh's question. If a person presents with a testicular tumor at 70 years, is it likely to be a favorable tumor, an unfavorable tumor?
Sir, mostly it would be lymphoma, sir. So it's
Is it likely to be a favorable tumor or an unfavorable tumor?
there is unfavorable, sir.
Unfavorable. So that's what he was asking you. Anything in the patient's profile which is not in his favor. The question was not about in favor of your diagnosis, but not in favor of the overall outlook for the patient.
What does this?
Does this make it good for the patient, bad for the patient? Normal markers.
Sir, bad, sir.
Why?
Because somehow it rule out lymphoma, sir. No, it is in favor of lymphoma, sir.
No, why?
Because in
What are the tumors in the testes which can have normal
lymphoma? If there is a pure lymphoma, you would expect the LDH to be very high. Pure lymphoma, nothing else. Doesn't mean, but because there are various varieties of lymphomas, some varieties will elevate the LDH significantly.
What does this tumor markers tell you? What type of malignancy you are dealing more likely to be?
Germ cell tumor, they mostly tell us about germ cell tumors, sir, tumor markers.
How are they classified, man? You are telling germ cell tumors. Germ cell tumors are of what types?
Seminomatous and non-seminomatous.
Good. So out of this, what is more likely?
In this age group, sir, 70 years.
No, with this tumor marker.
It look in a seminoma, sir.
So in what percentage
Can
of...
it be anything else?
Sir,
Any other
it can
tumor?
be seminoma, or teratoma, sir.
At 70 years, what else can it be? See, always keep that age. That is why Dr. Ganesh asked you that question. We are not dealing with somebody who's 40, 45, 25, 35. We're dealing with somebody who's 70. At 70, a person with a testicular tumor, negative for tumor markers, what are the possibilities for the testicular pathology? Assuming that it's a tumor, what type of tumors could these be?
Sir, it can be lymphoma, sir, or sex-cored gonadal stromal tumors.
At this age, 70 years. Can there be some tumor type which is very aggressive, very bad, but doesn't express any marker? It happens in several organs in the body.
Lymphoma, sir.
Anything
You
else?
are stuck with lymphoma, either you are digging your own grave or somebody has told you this case is lymphoma. See,
What tumors are common? What histological type of carcinomas or tumors are more likely with advancing age? Well differentiated ones, poorly differentiated ones, intermediate ones. What happens as age advances?
Sir, in old age,
I think there's luck here. So generally, with advancing age, the differentiation comes down. Okay, so if you have a testicular tumor, which is not expressing any marker, besides lymphoma, we also think of the possibility of an anaplastic carcinoma.
Okay, sir.
Get it? And of course, it can be seminoma.
Yes, sir.
To complete the questioning in this direction, if this man was younger, then a 6 centimeter tumor with negative tumor markers is in favor of a seminoma. But the size of this tumor itself is 6 point something centimeters. And by size criteria itself, this is not a good thing, although it is still a seminoma. The same thing translates to an elder person. If it is a seminoma, then he can have a spermatocytic seminoma, which is a good prognosis. At the same time, it doesn't mean that with these tumor markers, which are normally at this age, he has only a seminoma. He could have a lymphoma or he can have an anaplastic tumor. So you see, the range is different. And that's what we were trying to get at from you. So you must have some idea of the pathology of these conditions so that you can answer these questions, okay?
Okay.
You got it?
Yes, sir.
Right. Let's proceed.
So on USG scrotum, it's showing heterogeneously hypoechoic lesion in right testis. So it is in favor of the testicular tumor.
Why you want to do an ultrasound scrotum?
Sir, ultrasound scrotum is just extension of the physical examination. So,
That will not hold water anymore. You can't, in this day and age, say it's an extension of clinical examination. If you want to do it, what are you looking for? That's what is expected. Not that it's an extension of it's the stethoscope of the urologist or it's an extension of clinical examination. If you are doing a scrotal ultrasound in a patient with a hard scrotal mass, what are you looking for?
sir, I want to see any hypoechoic lesion in the testis and any necrosis inside the testis or any cystic nature. I want to see, exactly see the nature of the swelling, sir.
There are three things you want to see. You want to see the echo texture, you want to see whether there is blood flow, and you want to see whether there is associated necrosis. Right?
Yes, yes, sir.
Say that. Don't come with philosophical explanations, extension of the clinical examination. No.
Patient has to pay another 2,000.
These are the things you want to look at. And you might want to, in a certain age group, look at the opposite testis also for presence of impalpable lesions.
Yes, sir.
Anything else you want? Scrotum, you have already done it. Are you happy with the then you proceed with surgery or you want something more?
Sir, I want to proceed with high inguinal orchidectomy, sir.
Would you like to do CECT abdomen, chest or chest X-ray, or you are happy with the doing early orchidectomy?
Sir, after getting the biopsy report, we can plan because on the history and physical examination, it looked like that there are no chest and abdominal findings. And so after getting the biopsy report of orchidectomy sample, we would further proceed with investigations.
If the patient was somebody from one of our families or our relatives or friends or somebody, we would want to know, is this the end of the treatment? You remove the testis and that's okay? They
After
don't
biopsy
know that
report,
something more is required, and they want to know: are you going to treat me incrementally? Are you going to treat me at one go?
so we will wait for biopsy report. If
See,
biopsy
under
report,
what circumstances? Under what circumstances will we wait for the histopathology report before further imaging evaluation? And in what circumstances will we do everything at one go? Perhaps this is my reading. You're getting a little confused between the marker positive tumors and imaging. In a marker positive tumor, we do the orchectomy, look at the markers, and then proceed with the imaging to look for other sites of involvement. In a tumor which is marker negative, where one of your diagnoses is a lymphoma, would you want to wait until you have the biopsy of the testis? Is there anything lost by imaging at the same time? I would think you, in that case, you do the imaging and you'll be able to tell the patient, look, you got this, and this is the treatment we've planned for you, and this is what you should be prepared for.
yeah, right, sir.
No, you don't have to
As a
agree with
general
this.
rule of thumb, in today's world, it is always preferable to get all the facts before you actually put a knife to skin. This is not an emergency. Okay, he came in here and he's been having this trouble. So rightly, you will like to evaluate him and then go ahead. You want to know what's happening. So I would have said that 95% or 99% of residents would have said they would do a CT scan. And that's how it would be. The days are gone when it takes 4, 5 weeks, 6 weeks to do a CT scan. Even in the worst of circumstances, like even in the first world countries, there's a fast tracking for malignancy. So you will be able to get everything in one shot very quickly. Of course, in India it happens even super speed. So.
See, your tumor markers take 2 days to come, whereas CT you may be able to do the same day you see the patient. You need 4 hours fasting. You have seen the creatinine report. You can just ask for CT. Your tumor markers may come little later, whereas the CT report would be ready before that.
Proceed. Show us the CT scan.
Oh, you want an orchectomy?
CT scan.
Okay.
Please, next picture. First picture, please. First slide.
Maybe select the CT. Whatever other images they give, but the abdomen is there.
Sir, there is a.
So much time. What you see is what there is.
There is swelling in the right testicular swelling that is ill-defined.
Again, doctor, a swelling is a clinical terminology. What you find here is a testicular mass. There is an enlargement of the right testis with an area of different density, changing the shape of the testis, Whether you call it necrosis or you don't call it necrosis is what you should be telling us. And you should also be telling us whether there is any other obvious finding. You can see the opposite testis. You should tell us how the opposite testis looks.
The right testis is enlarged and it's ill-defined and heterogeneous. Laxity, and the left testis appears normal in shape, sir, size.
What is the reason you have done a CT abdomen and just CECT?
To check any lymph nodes in the abdomen, retroperitoneal areas, or involvement of any visceral organs.
Okay, show the other.
Why is that important?
Because
Why is that important? Why do you want to look at the lymph nodes and the other organs?
sir, to plan our treatment, sir, we have to check whether lymph nodes are involved or metastasis is there.
You know, intelligently, you would have said that you're also looking for a lymphoma. Right? This might not be a primary testicular lymphoma. It might be part of lymphomatous involvement in a generalized lymphoma. Dr. Ganesh told you there's a spectrum. So doing an abdominal CT will show us other lymph nodes, will show us presence of splenomegaly, hepatomegaly if it is present. And if we include the chest, we might also be able to image the mediastinal lymph nodes. Okay.
Yes.
Normally, which lymph nodes you are expecting to enlarge in a testicular tumor?
Retroperitoneal lymph nodes, sir, in this para-aortic, this right side, the intra-aortocaval, paracaval, these lymph nodes in this testicular tumor, sir. And in lymphoma, any lymph nodes can enlarge, sir.
Is the pattern of lymph node involvement varying between types of lymphomas? See, broadly, we classify them as Hodgkin's and non-Hodgkin's lymphomas. Is there any difference in the distribution of lymphadenopathy in these conditions? And at this age, which type of lymphoma would you expect?
It's a non-Hodgkin's lymphoma in the 70 years old.
Yeah. What is characteristic about lymphadenopathy in non-Hodgkin's? Or you want to answer it the other way? What is characteristic of Hodgkin's?
Sir, there will be in Hodgkin's, sir, all generalized continuous lymphadenopathy will be there, sir. From top to bottom, sir.
Is there, sir, top to bottom, from the head down to the toe? Don't use such terms.
Supraclavicular, mediastinal, retroperitoneal, and inguinal.
So you have axial lymphadenopathy and you have acrolymphadenopathy. Correct?
Yes, sir.
So, and in which type of lymphoma is extranodal disease more common?
Non-Hodgkin, sir.
And which type of lymphoma is more common at 70 years of age?
It's also non-Hodgkin, sir.
So you see now why it is necessary to do a CT?
Yes, sir.
Yeah.
So you have seen the CT. We will, I think, just take some.
Just
Okay.
give
So
you
anyway, we'll
information.
assume that chest is normal.
Prabhu, just to
Yes,
give,
sir.
give an information to our resident, there's a famous line which was made by Thomas Hodgkins himself. He said, tuberculosis follows me like a shadow. And if you can remember what are the type of nodal distribution in TB, it will be identical to Hodgkins. So you can remember that, and you will see that, the way it is there in non-Hodgkin's lymphoma or lymphoma which is solid is different. So this helps to understand what Mohan was talking about. Okay, Karen, sorry, just to give some information on that.
Yeah, next, you have told the patient that you are going to do a right high inguinal orchidectomy. Patient says, can I come after 2 weeks, sir? I have some important work to do.
Yes, sir, he can come, sir. There is no emergency in doing surgery. We can wait for 2 weeks.
He says, can I go to a foreign trip 2 months and come back?
To answer this question, if you're asked this as an exam, please look at the complete picture. You're not just going to look at whether it's a matter of 2 weeks or not. Where is the patient from? Can he travel? Is he likely to come back? Does he have a support system which will bring him back? And are there any medical conditions which might get worse if he waits? And therefore, you would like to do what you want to do at this point. That's better than shooting off an answer saying, yes, sir, he can go and come back. Okay, so you'll answer saying, sir, I'll find out where he's from, whether he can come to the hospital on time, whether there's anybody who can bring him to hospital, whether he's got medical problems which are likely to get worse or which require to be controlled in the meantime. Based on that, I'll say, yes, he can come back a little later, or no, he should get hospitalized now and complete his initial treatment. Okay.
Okay.
Yeah, Prabhu.
See, it's some kind of semi-emergency in the sense the testicular tumors can rapidly enlarge and it can rapidly spread. So we should not be telling him to come at his own. It's not like elective inguinal hernia surgery where he can plan this thing. It should be done as early as possible. I agree, if he's on some clopidogrel and all, you may have to adjust that, but otherwise it is relatively early orchidectomy has to be done.
In the early days, it was considered an emergency or a semi-emergency. They would put him on the list the next day. If he came today, he would be on the list the next day. That sort of stuff. As you rightly said, of course, there was one variety of tumor, which was the original classification, which was very rapidly progressive, apart from choriocarcinoma. This is the so-called galloping tumor, hurricane type of testicular cancer, which was classified by Gordon Taylor as the embryonal carcinoma, which is very aggressive. So those are all the old days, but it just to amplify what Prabhu was talking about, that yeah, there is an urgency about this. Not, you can't just be, oh, come back after 3 months and all. No, that's the general idea. What is Shavasu maneuver?
In Shavasu maneuver, we do inguinal incision and first apply clamp over the deep ring over the spermatic cord and then retrieve the testis, and we freeze it to decrease the bleeding, and we cut it into 2 parts. And
you said freeze, eh?
Sir,
you freeze the testis? That means you put ice around it, is it? Like for kidney cooling. Is that what you do?
You should also be careful when you say clamp, you apply a vascular clamp or a soft clamp, not a arterial clamp, not the conventional artery forceps. Okay. But what do you do? You dissected inguinally and you got a bulldog around the proximal cord.
Did you read somewhere about freezing the testes? Are you still there or offline?
Are you still around? Are you answering this question or do you want to let it pass?
I think he could have a connectivity problem.
Yeah, possibly.
They're offline, sir.
They're offline. Okay. Anybody?
What's the final story on this step?
In presentations, as far as possible, please anonymize everything, detail, whatever can be anonymized.
Hello.
Oh, you're back, no? I think they had some connectivity problem.
Yes. Electricity went down.
Okay.
Ah.
Yeah, I mean, you will have to read up Phimosis maneuver again.
Yes.
But in the meantime, they took your advice, went ahead, did an orchiectomy, and this is the histology report.
Next slide, please.
Why do they have this?
We'll-
You did a biopsy, they've done a histology, everything. Why is the confusion arising?
Frankly, to me, the histological description does not fit into the seminoma.
Exactly.
Seminoma is one of those most monotonous slides. You know, everything looks the same. There's no variation at all inside it. And spermatocytic seminoma is a very good variant. Here they have described, you know, sort of various changes inside, you know, small lymphocyte-like cells, diffuse pattern, loose collective tissue,
Nucleoli, mitotic forms,
large nuclei, prominent nucleoli, many mitoses.
apoptic bodies, all lot of things.
But anyway, they are pathologists, we are just clinicians. But this description, if I'm just given that, I would say, well, it doesn't look like clear seminoma to me.
Actually, you know, there are three tumors which are close histologically to one another. A seminoma, or a small cell tumor, and a lymphoma. A small cell, I mean anaplastic. So these three will have identical cells. And therefore, it might be a little difficult, especially in the older age group, to histologically differentiate this purely on histopathological examination, that is conventional H&D staining. But there could be certain markers. In this case, can you tell us anything which tells us that this may be anaplastic?
By IHC markers, we can differentiate only.
No, not IHC. On the basis of histopathology, the description given here, is there anything that suggests that this may be an anaplastic variety?
I don't know, sir.
Is this likely to be a very aggressive tumor, intermediate tumor, or a less aggressive tumor?
But less aggressive.
Why so?
Because there is no lymphovascular invasion is present, and the tumor cells are
Are all the cells uniform?
yes, sir, almost, sir.
Look at it. They say 3 types of cells. The very first line. Are there mitotic figures?
Small lymphocyte-like cells and 2 giant
Are
cells.
there mitotic figures? There are mitotic figures 2 to 4, you can see there.
Yes, sir.
And what are these apoptotic bodies?
2 apoptotic bodies are noted.
Correct. What are these? What are the apoptotic bodies? Looks like
Hello.
we've lost them again. No?
Hello. Sir, am I audible?
Yeah, you are. See, I know this is an error that is often committed. We only want to see the last 2 lines of a histopathology report. What is in the description is equally important. When you look at this, you can make out this is a rapidly multiplying cell line. There are mitotic bodies. If there are apoptotic bodies, that means that cells are also vanishing quickly, which means it's a more aggressive form of tumor. And therefore, one possibility is it might still turn out after immunohistochemistry to be an anaplastic variety of tumors. Okay, this is how we should think when we look at the histopathology report. Dr. Ganesh, you want to add anything?
No, nothing. Let's see what the final histology is. We are interested in that when it comes. So, from where is this case? Prabhu?
So we have sent for the IH markers. Yeah, next.
Just let us know at some point when it comes in.
No, it's ready, sir.
Sorry?
Next slide, it is there.
Oh, next slide.
There's one more slide. Okay.
Spermatocytic.
Very good.
CD117.
So the biopsy report has come and patient is again asking, can I go on a foreign trip 2 months?
Yes, sir. He can go, sir, because spermatocytic seminoma is benign tumor, sir.
Benign tumor?
You can't use the word benign. It's not a benign tumor. Use a better term so that you can still allow him to go on the foreign trip.
Sir, only 3 documented cases of metastasis has been.
Can't call it benign.
See, it's a malignant tumor it is cured by orchidectomy most of the time. It has good prognosis. That is the way you have to tell rather than saying benign tumor.
Metastatic potential. Its metastatic potential is very low. And therefore, the risk of metastasis with a little delay in surgery is unlikely to adversely affect him. However, we have to go back again to all that we had discussed. Whether we operate now or later will depend on his social circumstances and his ability to come back or willingness to come back.
Yes, sir.
Right.
So, but do you still follow up this patient or tell him?
Sorry?
I mean, I'm asking, so are you going to follow up this patient or tell them no need to come back?
More importantly, if you're following up, how are you going to follow this patient up?
So actually, this tumor has less metastatic potential, but I don't know exactly, sir, but we can follow up by doing CT abdomen, sir, to check any metastasis later on.
Which is the commonest site of metastasis in such a tumor?
The retroperitoneal lymph nodes, sir. Retrocaval, paracaval, interretrocaval lymph nodes.
How about the chest?
Right side.
How about the chest?
Chest also, in chest also they can go. Mediastinal lymph nodes.
Don't you think it's better to do a simple chest X-ray on this fellow and an ultrasound or something like that rather than keep doing CT scans for him? Because each of those CT scans is going to pump him with some radiation, and you're going to do that what? What's the frequency of this protocol, of this follow-up? It's not as dedicated as for a younger person with a seminoma or a NSGCT. So you have to change your track here and be less aggressive in your evaluation post-operatively for meds.
Okay, good.
Yeah, so look at where it is going to be most common is the chest. So do a chest X-ray, and then you don't have to do it at 3 months and all the rest of it. These guys, you can see them at 6 months, maybe biannually, and be done with it.
Yes.
Do you need to keep examining this patient? Of course, you're doing the chest X-ray and ultrasound abdomen.
Is there a risk of developing a similar tumor in the opposite test?
No, sir.
So do you need to keep examining it? Can there be a local recurrence?
No, sir.
So these possibilities are low, and therefore routine surveillance may not be required. But since it is a malignant tumor, you would like to have some kind of surveillance for metastasis in the lungs, in the abdomen. And when you're getting that, then you might as well examine them locally. But it isn't.
One of the features of spermatocytic seminomas are the fact that they are bilateral. So that is the reason why Prabhu asked this question. Would you like to examine the testes, the opposite testes? So, yeah, you should put your hand on that because many patients at this age will not be able to do self-examination of the testes. So,
The reason I told is most of the time you don't ask the history also, don't ask the exam, don't touch the patient also. You are stuck with the guideline and the patient has some other major problems, you ignore it. I mean, it always, it starts with history, clinical examination and specific test if at all. So see whether the patient is gaining weight, see whether he has any problems, attend to it. He may be having other problems like BPH also, but history, examination, in addition to the specific test.
Yes.
I think today we've finished on time. Can we end here?
thank
Yes,
you.
sir.
Thank you.
Thank you.
Thank you. We'll catch up next week. If there's any further follow-up on this, I'm sure Dr. Prabhu will let us know a few months
Sure.
before.
Sure.